So, hi, good afternoon, all. So, I hope we'll have a very interactive session. At least those who are able to switch now and then, maybe if possible, you can unmute yourself and speak out. And if not, that's not possible, you can always use the chat box and convey your feelings or your thoughts, any queries, any such things. Okay. So, yeah, we'll start off with communication. This is a very short and brief session. So we'll try to be as interactive as possible. Okay. So why do we need communication? Why are we focusing on communication? Any thoughts? Why is it that we have an entirely two sessions entirely for communication? One is for basics of communication, and the next one is breaking bad news. So why do you think that this is important? Any ideas? Hmm? Okay, fine. We'll start off with a study which was done by the headache study group of the University of Western Ontario. So they found that most of the patients that came to them, like obviously they came to them because of headache or something like that. Mostly it was headache. Okay, most of the patients that came to them with headache. After having a very long conversation with the physician, they found their headache to be relieved. Okay, so that was the study, and it was found that the patient's perception that they had an opportunity to tell their story and discuss their concerns about their headache fully with their physician during the first visit kind of was a big relief, right? So the fact that they were given a space to actually say about their concerns, it might be work, it might be stress, it could be anything, but they were given a space to explain their story, discuss their concerns, and this somehow that communication, that conversation along kind of brought, they found it be very relieved, they found it be very satisfying. So this actually shows the importance of communication. It what we do generally is that once a patient comes in, we may look at the patient, we may not look at the patient, we might know the name, we don't actually give any importance to any of these factors. So what we do is that we immediately prescribe some medicines and give off. We won't assess why the patient is having any if at all the patient is having any concerns, why the patient is having headache, or is there any other reasons to explore. So we'll just give tablets for the headache. Maybe it's just a mild headache. So okay, fine. These medicines might be working out for you, and we'll immediately dismiss the patient. So, and the patient might again come back to us again saying that okay, the headache has not reduced. So this shows that the study shows that a mere conversation with the patients regarding their headache, regarding the concerns, regarding their other factors that were like making a trouble for them, kind of relieve their pain. So that is one important thing that why we use communication. Another thing is that 60 to 70% of the medical errors that usually occurs in the occurs is as a result of poor communication. So what happens is that either the patient won't have a clear idea of what the diagnosis is, what the prognosis is. We might be actually saying everything from our end, but it may not be actually reaching the patients. The patient may not be perceiving the message as such, and there might be delay in some kind of what do you say? It could for example, I would say so there was this patient, yeah, there was this patient who came and she had certain issues where she was not willing to take medicines. Okay, so she thought that okay, anyway, I'm having cancer and it is so and so stage, and even if I take the medicines, it may not be helpful for me in any way. So even my aunt and my mother had similar conditions, and one for my aunt, the medicines kind of helped, and for my mother it didn't. So there is this misinformation is there with this patient that okay, even if she takes or does not take, her condition is going to be similar. But we have to like sit with the patient and say how this her stage or head position or head state is different from that of her aunts or mothers, and how things have changed, maybe how this medicine is going to help her. So most of these kind of errors can be prevented, and a lot of other errors can also be prevented if there is a proper communication. So right. And when it comes to a doctor patient relationship, effective communication is very important because this increases the diagnostic accuracy. It is also helpful for patient compliance. For example, if they are not willing for treatment, if they are not willing to take medicines and all, if we have a proper communication, proper communicating channel, then the patient compliance to adhere to the medication, to the drugs that we are prescribing is more when there is effective communication. And by that, the patient satisfaction also increases, team satisfaction increases. See, there is this physician who is seeing a patient, okay, and there is this nurse who is seeing the patient. There is psychologists, there is social officers, there is physiotherapists. So the whole team is seeing. And even if we keep the communication without, if we withheld the information without sharing this to other team members, this can also affect the quality of the treatment that we are giving to the patient. So the team satisfaction also increases when there is proper and effective communication among the team members as well as among the patient as well as the physicians. And also patient safety, chances of litigation is also reduced. So, right, the doctor will see you now. I can't promise that. See, you can see a caricature beside the presentation. The doctor will see you now. I cannot promise that he will talk to you, but he will see you. See what kind of a message we are giving when we say that he is like busy, he is having so many patients, and we are like we can see that there is threat and there is this uncertainty in the patient's face. So these kind of things can be avoided if we have a proper communication channel. So mostly when we talk about communication, there is hearing and there is active listening. Can you know? Can you just someone say the basic difference between hearing and active listening? I guess most of our team members are just hearing and not listening or actively listening. Is that the case? I know the time is like post lunch and it's usually a bit drowsy and we won't be as active, but try to communicate
Ma'am,
as much as possible. Yes, sure, I can hear a voice here.
yeah, ma'am, active listening is much more better than caring.
Right.
It is more active. I mean, it is more better than just caring. Caring is a lesser attitude, and active listening is more better.
Right. Thank you so much, Rajpreet. And I think there is Divya who has posted in chat box. Active listening is understanding what the patient is trying to say. Active listening is processing the information. Okay, so I'm here. I'm taking this session and I'm telling about communication and all. And people, I mean, I have a few participants, right? I have like 75 participants. Maybe out of this, maybe most of half of them might be just listening. Maybe half of them might be listening to me. So hearing is just passively. We are physically present there. We are not comprehending. We are not perceiving what the presenter or what the other person is saying, but we are physically there. We are hearing, but we are not processing what has been said to us. Okay, so when it comes to active listening, we actively comprehend, we try to merge the information that we are getting with our already existing existing information. We try to comprehend what is being said to us. So active processing, it's more like in we go in depth of what is being said to it. It is the successful key in any communication. Thank you so much, Shivani. So, what we focus mainly when we are communicating, forget about a patient. Even when you are conversing with any other human being, just make sure that you're actively listening. And active communication is a key to successful relationship, and active listening is a key to communication. So you have to be not just physically be present there, but you have to actively process the information, comprehend, and maybe in some way we have to let the other person know that we are listening to what you're saying. Like, for example, I have a few participants who's like responding to me, who's like unmuting and speaking. There are few people who are using the chat box. So I know that these people are actively listening to me. They are processing the information. They are using these channels to tell something back to me. So this process happens when we actively listen. So active listening is a key to a successful communication. So, what are we covering today? Some positive body language for active listening. So, when we are communicating, what we need to focus is the active listening. And when we are doing the active listening, there are some certain body language, there are something traits and certain tricks and certain cues that we have to skillfully develop for active listening, and some helpful do's and don'ts in the active listening. So what are we supposed to do when we are actively listening, or when we are communicating, what we shouldn't be doing? So these aspects will be covered in the coming slides. So you can look at the picture. It's what's the emotion of the child? What can we make out from the child's face or the body language that the child is showing?
She's upset.
Disagreement. She's upset, right? Child is fed up. Thank you, Gautami. Thank you, Shivani. Thank you, Dishchan. She's upset. So just imagine I'm right in front of you. Okay, so I'm having a very awkward body language. Okay, I'm just lying back. I'll just sit back. I'll have very grumpy face on me, and I'm taking this presentation and have a conversation, or I'm having a conversation on communication, having that body language. How is this going to reflect upon you people? It's going to affect you very negatively, right? So the body posture itself gives off so much information regarding how we are mentally, cognitively present in the communication. So body language, we may not even be sometimes be aware of how we are carrying our body, how we are keeping our hand, how we are keeping our legs. All these minute things give off a lot of messages when it comes to communication. So are we aware of how our face is, how our body is, how our hand is held, how our legs are kept? So are we aware of this? See, the child is saying, I can't be held responsible for what my face does when you talk. The emotions that we give off unconsciously. Maybe we may not be even conscious that we are giving off this messages. So these are certain aspects that we need to control and skillfully develop, so that we have a positive, very effective communication, right? So Albert Mehrabian's model says that only 7% of the whole communication is being taken up by the spoken words. So whatever we are saying, whatever we are communicating verbally is only taking up of 7% of the total communication. The 38% comes with the voice and tone that we use. But 55%, just imagine, of the 100% of the whole communication, 55%, that is more than half of the communication percentage, is being taken by the body language. How we keep our body, how we use our hands, how we use our the way we keep our hands, legs, etc., the face, etc. So 55% of the total communication is being taken up by the body language, and 38 is being how we use our tone. Whether if I'm speaking to you throughout in a very monotonous, grumpy, throughout I'm using the same tone, I won't be able to catch your attention. See, the tone and voice has like 38% place in effective communication. The verbal things, whatever I'm saying, is going to take up only 7% of the communication. So just imagine the importance of having a very positive, very effective body language for having a proper communication, as well as the use of our voice. Right. So what are some of the positive body language? So what are the things that we need to emphasize on, we need to focus on, so that we have very effective communication? And one of the most important thing is eye contact, right? So I'll just read off all the things, and we'll be like looking into each in detail, I guess, right? So eye contact is first and foremost important thing. Facial expressions, tone of voice, body position, body posture, body space, and touch. So these are the 7 elements of body language that we need to look into so that we have effective communication. So the first and foremost is eye contact. Okay. Just imagine I'm sitting in the consultation room. Okay. I'm sitting in the OP and I have this patient who is coming over from there. Okay, so I have this patient coming over. I won't even look at his face. I'll be like reading the file that is being kept in front of my table or in front of me of the patient. It could be the file which is saying things about the patient, the needs, presenting complaints, everything might be there. So the patient has come. Maybe the patient is looking at me, but I'm not even aware of the patient is whether he's looking at me or not. I'm not bothered about who has come, who the person is. I'll just right away take the file that has been kept by the nurse. I'll be reading through the file. So that moment itself, the relationship that you are going to have this patient is like he's like hindered, right? So the very first moment a patient is coming into your room or is going to talk to you, just make sure that no matter what you're doing, maybe you are looking at, you're scrolling through your phone, maybe you are just reading through the file, the case sheet or whatever, and make sure that you take off your eyes from whatever you're doing and make a proper eye contact with the person who has come to talk to you. Okay, so that moment itself, a relationship, the rapport has been established properly. So make sure you look into the person's eyes, make a proper eye contact at that very moment. So how to make a proper eye contact? So these are some of the tips for making proper eye contact. When you look, do it slowly. It's not that you can abruptly look at someone, in a shock, or the movements has to be very slight and very slow kind of movement. So you cannot look in a rush, just take your eyes, look at them and just come back. Not, it's not a very abrupt, sudden, a dash kind of movement. It has to be done very slowly. You look at the person, you take a moment, you make sure that the a person has caught your eye contact. That's how you make the proper eye contact. Don't look down when you look away. So the person has come, has sat beside you. I'm like talking to the person, and I might be looking at the person. Maybe we might have to look into the file as well, to maybe to read certain information, maybe to know about some other information. So we might have to take our eyes off the person. Okay, so just don't abruptly look away. And when you are completely having a conversation, make it slow. You can just gradually take your eyes off. And when you're completely having a conversation with the person, make sure that you don't look down. It's looking down, it means that the patient might have a lot of uncertainty, ambiguity, and a lot of kind of what, okay, what if the looking down will cause a lot of discomfort in the person who is sitting in front of you. So never look down when you want to look away. Okay, so you want, I see, we are humans. I do understand that we cannot completely maintain eye contact throughout a conversation. Or it might be, we might also feel like, okay, the fatigue might be there. We might actually derail in our thoughts. This can be possible at times. Okay, so at that time, what has to be done is that look somewhere else. Okay, you can take your eyes off the eyes of the person who is sitting in front of you, but you have to look some spot other than the eyes. Okay, you can look somewhere else in the face. It is actually called as a good triangle. I'll coming to that. That's the next slide. So rather than looking away or rather than looking down, if you feel that you need to take the eye contact away, or you need to take your eyes away from the person who is sitting in front of you, maybe you can look at some other point. Thank you, Shivani. Right. You can look at some other point than the eyes. Maybe you can look somewhere around the chin area. You can look somewhere around the central area. So it is called as a good triangle. I'll come to that. Break your gaze to make a gesture or note. So if you feel like taking a break, you cannot completely, you cannot just stare into someone else, right? So if you feel like you need a break, you can just node. Maybe you can just slightly node in what you say, in regard to what the patient is saying. Maybe you can just make a note, maybe make some words to say, okay, I do understand these kind of gestures. right? Not the central part of the eye. This is the good triangle. Okay. This is the good triangle. So if you want to take your eyes, gaze off the eyes, and you want to look somewhere else, maybe you can look somewhere else in the face. Okay. And the best points are these 1, 2, 3 points. Maybe you can look somewhere around the lips or chin area. Maybe you can look at the lateral side of the triangle, the right side, the left side. Maybe, this is the best way to take your gaze off. This is called as the good triangle. And even if this good triangle does not work, maybe you can look at the somewhere else in the head, in the face area, maybe the cheeks, the forehead, anyway will be fine. But this good triangle is effective, gives us a proper effective communication, right? So eye contact is one of the most important thing in establishing a proper relationship, as well as in having a very effective communication. So the gaze has to be very slow, and if you feel like taking your eyes off, maybe you can nod to take breaks. And if you want to take your eyes off the complete gaze, maybe you can look somewhere else in the face. Right. So the next important factor is smile. So no matter if you're wearing a mask, or even if you're, what do you say? Well, okay, I'm wearing a mask. So even if I smile, the person is not going to get to know whether I'm smiling or not. We have this apprehension. So even though you're wearing mask, the smile can be seen through the eyes and can be heard through the voice. Okay. And the social smile, the professional smile is something that we need to develop in our practice. It is not something that you can do, not something that you can develop in a day or two. This comes with practice. So make as much practice to have a very social professional smile. Just imagine, okay, I'm wearing a mask. Even if I'm wearing a mask or not, okay, a simple smile might bring a lot of change in the way you're communicating. Maybe for example, if we move on to the next slide, that is the next element of body language, the tone of your voice, right? So just imagine I'm having a very grumpy face as the red smiley that is over here. Okay. So I'm having a very grumpy face. I'm not smiling. I'm very angry. I'm having a grumpy face. So how am I going to sound? So just try yourself. Having a grumpy face, we can never sound polite or kind, right? Having a grumpy face, your voice, your tone is also going to be very grumpy, right? So, if at all you want to have a very nice, polite, kind of conversation, the smiling is a root. And the moment we smile itself, we are going to sound nicely. So, the tone of our voice is going to be very kind, very smooth. So, you cannot have a smiling face and a grumpy voice, right? So, if you are smiling, you will obviously be kind. You will be like talking very politely. So, smile is very important. See, this kind of sets the base, the eye contact. It's the base is eye contact. From there, it's kind of started having very proper relationship. So then smile, and professional smile is something that we need to inculcate. We need to develop through practice. And smile, always remember, smile can be seen through the eyes and heard through the voice. So maybe even if you're wearing a mask, maybe you can just make a slight sound, or maybe you can just use your eyes to show that you're smiling, or you're in here, you're in present. Again, smile will make your voice, just make sure that you smile so that the tone will be also be in tune with your smile. So how we say always matter. So if you're saying something in a very rude, very harsh way, this is going to stay with the patient. See, I have had patients who had like reported, maybe she was actually visiting a government medical college, okay, and from there, I think pediatric medical college, and from there, the neuro doctor had spoken to her in a very harsh and very rude manner. Maybe she had to communicate the prognosis, diagnosis, and all, but it was conveyed in a very rude and very harsh. This is and so and so, and this has to be done, and completely saying in the sound that not setting a proper. Is there any doubt? Any? Okay. Okay. Anything else? Either the tone, the way we say, we say matters a lot, right? Okay.
मी
Right.
दुसरी आयुर्वेदिक अणुची येते
Sorry, Muskan, can you please mute yourself?
डॉक्टर कोण ना आमच्या पीएचसी झाला THC.
Okay, right. So, body positioning. So, while we are talking to our patients, whether it's in the wards or in our OP, the body positioning is very important. Okay. So, what can you see in the first picture? That is the left one, left picture. How is the communication between the doctor and the patient? How is it? Is it okay? Is it the right way? Do you think, this is how it has to be? Communication has to be done regarding the body positioning. Any issues with the first picture? That is the left picture, left corner. Right. Can someone? Please, I have like 95 people listening to me, okay? And uh, it's not necessary to unmute. Maybe you can even use your chat box. Eye contact a little higher than the patient, very good. Exactly. The patient has to look upwards. Good communication with eye contact and smile. The communication, the eye contact is proper. I do agree that, but as Deshan, right? I hope the pronunciation is right. As she has mentioned, as Jason has mentioned, the patient has to look slightly upwards, right? Yeah, the eye contact is perfect, but the patient has to look upwards. And he said beside patient in L position. Thank you, Veena. Thank you so much. Right. So in the first position, in the first picture, if you look at it very carefully, we can see that the patient is like slightly leaning forward. The patient is causing some strain to his back, right? The patient has to come out, has to like take his head off the pillow and come a bit slightly forward. There is strain around his neck and backbone, right? So, and eye contact is the level of the doctor the physician who is speaking, or the nurse who is speaking, is slightly higher. So, this again shows a very doctor in higher authority or higher position and when compared to the patient, right? But what are some of the positive side that is seen in the second picture? Like Veena has mentioned in the chat box, smile is there. The doctor is like sitting beside the patient, which is a very good positive character to have, right? So even if you don't have space and time to sit, make sure that, and you don't have the space to sit, there is no chairs or anything like that, and you need a very short conversation. Make sure that you stand at the foot end of the patient, okay? Here, the doctor is in the first picture. We can clearly see that the doctor is standing beside the patient, and the patient has to like lift his head from the pillow, and this is causing strain, a lot of strain in the patient, as well as there is this eye contact is something has to give up upward kind of eye contact and all. So even if you are standing and communicating, even if you're standing and talking, make sure that you stand at the foot end of the patient, right? So the patient can have a relaxed position. Okay, the patient will be relaxed. The patient will be like having the head against the bed or pillow and having a very straight kind of eye contact. So imagine having someone who is like standing in the foot end of the hospital bed or foot end of the patient. The patient will be able to look directly into the eyes of the physician or the doctor or the nurse, right? So make sure that the eye contact is in level. That the communication shouldn't be bringing any kind of what is a strain to the patient. Okay. So even if you're standing and speaking, even if you're having a conversation by standing, make sure that you stand at the foot end of the bed so that the patient will have a very straight level kind of eye contact. And this is the second thing. Okay. The first and the best thing to do will be to sit beside the patient, have a conversation, right? So try to find a chair, sit beside the patient. Again, the physician is sitting by the foot end of the patient's bed or the hospital bed. So here the physician and the patient is having somewhat in a similar level. They are in the same level, and the eye contact is also in the similar level. And the patient, the eye contact is proper, the body positioning is right, there is no strain in that is coming over the patient. The patient is comfortably lying and having a conversation. So this is the best way to communicate. So body leveling is very important. The equality that is there in our body. We physicians, the body position, the moment we stand and speak, this kind of gives of a very unequal. The equality is not that correct, and gives of some kind of authority or some kind of a dominance to the physician. But make sure that the equality is maintained. We sit beside the patient, we have a proper eye contact, and the eye contact is at the eye level of the patient, so that there is no strain in the patient. Okay, usually what happens when we are having a conversation with the pediatrics, we tend to bend down, right? We tend to bend down to the child's level. So what you need to do is that if you're standing, make sure that you bend down your knees. You have to like sit on your knees so that you are in level with the child. And the child will also feel that feel equal, and will feel his a lot of other factors is also working on here. The dignity factor, the leveling, the equality, a lot of other factors comes into place. So make sure that even if it's pediatric or even if it's adult cases, make sure that you are in level with the patient or whoever you are in having a conversation with. So usually with pediatrics, we bend down. Okay, instead of bending down, maybe you can use a chair or something to sit so that you are in level with the child, or you can bend on your knee, bend at the knee level, bend at the knee level, so that the child and yourself, the physician, the nurse, are in same level. Right? Any doubt in this slide? Shall we move on? Right. So next. So next is the body posture. So most of the time, this is exactly from what from the child's message that we got, right? The body posture also plays a very important role in giving proper effective communication. So if there is a patient, I'm not bothered to look at him, I'm not bothered to have a proper eye contact, I'm not bothered to have a smile, and I'm having a body posture which shows that okay, I'm least interested in this person. Okay, obviously the first body posture, I don't think we do that mostly in our medical or healthcare institutions, but we don't usually do that. I have not seen anybody doing that. But even otherwise, we might have a very lethargic kind of lazy kind of body poses. Maybe we'll just lie down. We might take our body back to the chair. We might just have a very relaxing postures. Maybe we'll have a mobile phone in our hand. So this body posture is also going to give off a very negative idea to the patient, or the patient might be maybe reluctant to say something if you are having this body posture. This gives off the idea that you are not interested to whatever this person has to say to you. This is giving off a very negative communication, negative information, negative message to the patient. So this shows that you're not interested. So the body posture gives off the information that how much you are interested. You are actively listening to what the patient is saying. So bend forward, bend forward so that your body is slightly forward. This body posture is showing that you are willing to listen to what the patient has to say, which will increase the patient satisfaction. The patient will feel, okay, I am listened to. There is someone who is like listening to me. So slightly bend forward. Slight bending forward will make a lot of change in the communication process in patient satisfaction. So bend forward instead of lying back completely and having a very lazy kind of posture. Make your back straight, bend forward to have a communication. Also, there is something called as mirroring. Okay, so if the patient is coming forward, is leaning, you can lean forward and speak. Okay, and if the patient is like taking a step back and leaning back, maybe you can also step back, you can also take a little bit the posture back. This is called as mirroring of the person who is sitting in front of you. Will make you, this is more to do with the psychology of it, will make yourself more likable. Okay, so I am mirroring of whatever the patient who is sitting in front of me is showing, right? So if the patient is leaning forward, maybe I will slightly lean forward to have a conversation. If the patient is leaning backwards, I will also take a step back. Maybe I'll also lean a little back so that we are in tune, we are in tune with their body postures. So this will make you more likable, right? So the next area is respecting the body space. This is very important. So most of the time, what we see is that, so there is this proximity areas. This is like commonly, we are commonly aware of this. So we have very intimate space, and then we have personal space, then we have social space, as well as public space. So the intimate space is a space that you like you share with very maybe your family members, your close people. It could be your spouse, it could be your parents, it could be your siblings, whoever you consider that close to you, right? So that is where the intimate space, the space that we consider as our own, that we just have a very few people who come into the intimate space area. Then we have the personal space, in which we have our close friends who come by, other family members who come into. So that is our personal space. Again, that is limited to a few people. And then we have the social space. That is a space where we usually have a conversation with, like for example, our institutions where we work, maybe other, maybe college, the colleagues, that those areas where we allow a few people other than the family members to come into, right? For example, our colleagues. Obviously, if we are in a working space, we have like colleagues coming in. So we have that social space where we allow certain people to be inside. And then we have the public spaces. So inside the public space, we allow certain strangers also to be there. For example, maybe you're standing in a railway station, maybe you're standing on a bus stand, and there are like a lot of people around you. Maybe there is one of your friends with you, and there are like other people around you. So this is like the public space. So we have our intimate space, and then we have a personal space, and then we have social as well as the public space. So we let only a few people into our personal space or the intimate, even very limited people into our intimate space, right? So you can clearly see certain characteristics in the first picture. What is it? Can you just sit with that picture, observe that picture, and say something regarding that? Anything. Maybe you can use the chat box as well. So how is the patient feeling? How is the physician behaving towards the patient? When we compare those, the first picture, what are the certain things? What are the certain characteristics that we can make out?
In the first picture, the patient is a little bit uncomfortable.
Yes, exactly. Thank you. Shocked, alarmed, very good, very nice. The first picture, patient looks feared. Thank you. He wants to avoid him. That is very evident from that picture, right? Second, patient looks comfortable and relaxed, right? Feared, afraid. Thank you, Hussein, Nancy, Veena, Angela. Thank you for the responses. Second picture, the patient is comfortable. The first picture, the patient is shocked and fear. So we can clearly see that the physician is like invading the personal space. The patient does not feel comfortable having the physician in that space. The patient is feeling threatened. The threat, that fear factor is clearly visible in his face, right? The patient is looking is shocked. First patient is not, the patient is very discomfort, and the physician's feels also, he feels somehow the body language is, maybe he is having a very polite conversation, but the body language itself is giving off the idea that in a very he is like saying something rudely, or he is angry towards the patient, or he is scolding. The whole body language, the expression, everything is giving off the idea that he is scolding the patient, okay, and is invading this personal space. The patient is has taken a step back. He doesn't feel comfortable enough. The patient feels that he has been invaded of his personal space, right? And in the second picture, we can clearly see that the eye contact, the body leveling, everything is in tune with the patient. There is proper eye contact, there is respect. We can see that both of them, at least the physician, at least is smiling, and the body leveling is equal to the patient. So we always, we most of the time, what we do is that, right. So most of the time, what we do is that there is this implied consent from the patient. So whoever is visiting us, we have this feeling that okay, they themselves have come to visit us, they have this trouble, and they themselves are visiting us. So there is this implied consent is there. Okay, I do understand that. Even though there is implied consent, before we invade their personal space or intimate space, make sure that you take consent for that, right? Just make sure that you take consent for whatever things that you're going to do. For example, there has this patient who has come to your OP. Maybe the patient needs catheter change, right? So we won't just remove the tube and insert the new one. We won't do that. Obviously, the patient has come for catheter change. I do understand the fact that the patient has come for catheter change. The patient also is also aware of the fact that the catheter is going to be changed. But before invading their personal space or the intimate space, before just randomly removing the tube, just make sure that you tell the patient, okay, see, I know this is going to be a bit discomfort or is going to be causing a bit discomfort for you, but I'm just removing the catheter, so it has to be changed. Shall I do that? This is going to make a remarkable change in the relationship that you are having with the patient. Just letting them know before you do something, before you invade their personal space, although there is implied consent, is going to make a remarkable change in the relationship, in the communication. In the long run, this is going to, they're going to always remember this. The dignity is preserved. Most of the time our patients are bereft of dignity. You just remove the catheter, you insert the catheter, you pull the gel, you do all those stuff even without taking any consent. And there are certain patients who may not comprehend or who may not be verbally able to say something back. For example, for severe patients, maybe their speech is slurred, or for patients, there might be patients who are not able to verbally respond to you, right? So even though they are not able to comprehend, even though they are not able to respond back to you, make sure that you do your part. Okay, see, I'm going to insert this catheter, and I know that this is going to cause a discomfort. Okay, shall I do it? I'm going to do this, and we are just saying that, and we are doing our job. Okay. And even when it comes to rights to or anything, any change, any invasion of personal space or intimate space that we are going to do, especially I think nurses will be more aware of this, right? So we are the ones who are like mostly involved in their changing of these, and most of the intimate space might be taken by us, right? Maybe invaded by the nurses. So make sure that you take the consent before invading their personal space. We won't feel that comfortable if someone just comes and that politely taking the consent is going to make a great change. Any doubt in this area? No. Thank you. I can see a nod from Veena that there is no. Thank you so much. So we are moving on to the next slide. Touch. So this is the last part of the body language. The impact of touch is very therapeutic, right? Very therapeutic. It's not necessary that there has to be reasons for you to touch, right? The very mere fact that maybe you're having your rounds, okay, you're just calculating the BP or whatever it is, maybe you're just asking whether maybe you're taking rounds to know whether they have taken the medicines, and you're just having a normal conversation. And during that conversation, if you like slightly place your hand over their hand, that itself is going to be a game changer, because they feel loud, they feel okay, there are like people around me who understand that, it is very therapeutic. I know the effects we cannot quantify it in any way. The impact that a touch is making in a person is like unaccountable. Okay, so I know that after COVID and all, we have our own restrictions and all, right? We fear that obviously we have diseases, everything is there and it is communicable, or we fear we have to like see other patients also. So we might have our own apprehensions and all, but make sure you can use sanitizer. Okay, make sure that you sanitize yourself before and after seeing each patient. And it is okay if you do this in front of the patient also. It is fine even if you do sanitize yourself in front of the patient itself, but make sure that you have a proper touch. It could be just having placing your hand on the patient's hand, it could be just patting on the shoulder, it could be anything. But this touch is does have a lot of impact. For example, when it comes to our sessions, okay, I'll say how it is important in our counseling or psychological sessions and all. Maybe the patient is might be saying a lot, okay, but he might, he or she might, just well up their eyes and all, but they won't. They will hold these tears back, okay. They won't let these tears out because they somehow feel, what do you say? They somehow feel maybe if I cry in front of you, they might feel like I'm weak or something like that. But at that point, what I usually use is touch. I'll just hold them. I'll just hold their hands. I might just put a hand around their shoulder. And that moment, they'll just start crying like anything. They'll just vent out all their emotions, all their feelings that they have kept with themselves for so long. That touch. If I don't do that, maybe they'll just hold everything back. They'll hold their tears back and they'll just leave the session like that. But that kind of touch is going to have a very great impact. So make sure that you have a slight touch also, right? So we'll just brush upon what we discussed. Provide proper care and support with questioning. So eye contact is the first and base of having a proper communication. After eye contact, make sure that you smile. The smile will cause a change in your tone, and you have to be very polite, very slow in having a conversation, right? So smile. The tone is going to be important. The body positioning is very important. Make sure if you're standing, make sure that you're standing at the foot, no, the foot end of the patient. If it is advised to sit beside the patient at the eye level of the patient and have a conversation. Even it's a similar for the pediatrics as well. And then there is this body posture. Always have it bent forward, lean forward, and there is called as something called as mirroring. If the patient has like leaning back, you can take a step back, but not in a very lazy, lethargic, fatigue kind of heated manner. Lean back, then just a step back and lean forward if the patient is also leaning forward. This gives off the idea that you're likable, you are listening and all. So always respect body space, even if there is implied consent. Make sure that maybe even before you put the stat, maybe you can ask, okay, can I ask put the stat? It could be a male doctor and there will be this female a patient who has come. There is a lot of issues like that, right? Maybe you can just take a consent. Is it okay? Can I put the stat? It's simple as that, right? So even if it's the catheter change, right tube change, whatever it is, in any way we are invading their personal space, make sure that you take their consent. Always the eye leveling, don't invade their personal space. Touch is very therapeutic, right? Okay, so we'll move on to the next part, that is some verbal do's and don'ts. Shall we? Right? Shall we move on to the next area? At least a few yes in our chat box.
Yes, ma'am.
Thank you. Right. So what we usually see in our OPN now, we tend to ask leading questions. Okay, that is the answer is all already there in the question that we are asking. Never ever ask leading questions to the patient. For example, so the patient was here with breathlessness, and we are asking, okay, your breathlessness is better now, right? What if the breathlessness is not better? What if? But we are already implying in our question that the patient has to feel better now, right? So your breathlessness is better. So we should avoid saying leading questions. In this, the answer is already there in the question. So never ask, you slept better, right? Always ask open-ended question. How are you today? Were you able to sleep? How was your sleep yesterday? So always ask open-ended question instead of asking leading questions, right? So don't minimize, don't compare patients' problems. So the thing is that we tend to, okay, so there is this patient who has come to me with a toothache. So I'm saying that, okay, you are just having a toothache. You have to go and see the regional cancer center there, where there are pediatrics, other population who are like having so much pain and all. So, but the patient who has come to me with a toothache, for him, the toothache is the biggest problem that he is facing, right? So we should never ever minimize a patient who is coming with a concern with towards you. Okay, so never minimize. Don't compare patient's problem with other patients. Okay, I had this patient who had so much, who was in stage 4, who had this so much. Who was going through so much pain. So now we are just saying about a random headache. So how can you say, see, this headache is causing a lot of problem to me. For me, this headache is causing trouble. I cannot work functionally because I'm having this headache. Maybe there are other people who are like suffering a lot, but for me, this is causing trouble for me. So never minimize. For that patient, whatever concern they are coming with is of higher importance. So there are many people who are facing much bigger. Never compare. They will feel you don't care. Okay, so acknowledge and normalize patients' emotional feelings. So what we need to do is that we should acknowledge their feelings. Okay, I do understand that this you have headache. I know that it could be very frustrating to have headache. So considering what you're going through, it is normal to feel. I know that it is, you're going through so much. So obviously it is, I do understand that it is evident that you have to feel all these things. We acknowledge whatever the patient is feeling, right? So acknowledge and normalize patients' emotional experience. We need to acknowledge their emotional things, emotional feelings. Never ever give false hope. Okay, don't worry. We are here with you. We'll take care of your child's health. We'll make sure that this is relief. There is cure for this. Never ever give false hope. Whatever the patient is going through, we need to actually communicate. How we need to communicate? We'll be like taking on the session in the next session. That is breaking bad news. How to like give off the information, but never ever give false hope. Okay, never say you will be completely all right. Never say I will be completely able to take care of your pain. What if we cannot be able to? Whatever is the fact, actual fact, we need to communicate that. So don't worry. Some of the exams are, don't worry. We are here with you. We are with you. We'll take care of all your problems. Do give realistic hopes. Give whatever the facts are. Your disease may be progressive, but I'll do my best to keep you comfortable as long as it is needed. Maybe I'll do the symptomatic management. We'll see what can be done for your pain. We'll see if we'll see what can be done to decrease your pain. So give realistic hope to the patient. Never ever give false hope. Do not assume. How is your breathlessness? We assume that the patient is much better. Never ever assume. See, I have given you so and so medicines, right? So this medicine is it would have taken care of your breathlessness. So this medicine might have improved your breathlessness, right? So we are assuming that the medicine has caused some positive impact on the patient, but this is not the case. So we never assume. Whatever information you need, get so you took this medicine. So what is it? Was it effective? Did you feel? How was it? So you can get the realistic answer from the patient itself, other than assuming. Okay, the patient will say, even if you're like in the leading questions again, so these medicines were given for you to sleep better. So you were able to sleep better, right? So the patient will feel that, okay, the medicine was given to me, so I had to feel better. I have to feel better. So the patient will respond in a way that, okay, I'm feeling better, right? So never ever assume or say in a way that in a way that gives off the answer. Never assume. Whatever information you need, you collect from the patient. Do you have satisfactory relief? Not really. So do not assume, don't give false hope, do not compare, normalize, acknowledge their feelings, give realistic hopes, ask open-ended question always. Okay, how are you? How are you feeling today? Right. So next is a very short portion, that is taking history, right? So taking history is a very important part of the communication. Maybe might be the first few communication that you do with your patient, while the patient has come to register to you, right? So we need to have a medical history. We need to have the patient's story, and we need to find out whether the patient has insight of the diagnosis and prognosis. So this is a main agendas or objectives of doing a history taking. So a patient has come to my OP. So the first thing I'll do is make eye contact. I'll smile and I'll do whatever is your native thing of doing namaste, namaskaram, whatever it is. Hello, good morning, whatever it is, right? So what is usually followed in your place can be done. So eye contact, I'll smile, I'll do a namaste, I'll offer a seat beside me. I'll make sure that the patient is comfortable. and in the in same level with me, or if we are having a rewards rounds and all, maybe you will sit down beside the patient. So start the interview with an open-ended question. So how may I help you? So what brings you here today? See, the patient is here. Okay, obviously the patient will be having certain concerns regarding his physical conditions, right? So what brings you today? What is the matter? Like, how can I help you? How are you today? If in IP we might be regularly seeing the patients, right? So if in IP we can you can ask how are you? How are you today? Listen, do not interrupt. So I do acknowledge the fact that we have limited time. We have so many patients in our IP. There are so many patients in our OP. So manage your conversations according to that. Okay, but don't miss out any of these things. Listen, and if you feel that the patient is derailing from whatever the patient has come to you and he's saying, bring back him. Okay, bring him back to the point again, right? So listen to their concerns. If there is time, make sure that you listen without interrupting, right? So listen to the patient. Encourage the patient to talk. During the conversation, maintain the eye contact. Nod your head from time to time. It's more like, showing that you're listening to the patient. Again, that's a body language. Make encouraging sounds. Please go on. I'm listening. Right. Clarify as you go along. I do not understand. If at all there is any point the patient is saying and you don't understand, make sure that you clarify. I did not understand. Can you please repeat what you said? Right. Ask about what they understand about the situation. Make sure that you get to know what the patient is having understanding of his stage. Right. What did the doctor there tell you? Do you know what the reports is? So obviously the patient will be coming with certain reports and all. Okay, so there is a chance that the patient might have already read what is in the report. So we need to have an idea what the patient has comprehended from those, right? So we need to have an idea of the patient's idea of the situation. So we'll be asking, what did the doctor there tell you? Do you know what the report says? Do you have any? Do you have an idea of what you're going through or what is happening? So again, the patient will start talking, right? So we'll have a better idea. Ask about their concerns. What are the major concerns as of now? What is it that actually is troubling you right now? Is pain? Is it sleeplessness? Is it something else? What is the main concern? Share information honestly. Use simple language, no medical jargons and big jargons and all. Use very simple language. We might deal with emotions also. For example, especially when we are like breaking a bad news, we are communicating there is collusion and all. When you're doing that communication, obviously we might have to deal with a lot of emotions. A lot of the patient might cry, the patient might throw off a tantrum. We can expect all kind of emotions surging up at that point, right? We might have to deal with that also. Discuss treatment options. So this is so and so condition. So these are the treatment options. Do not give a menu of options to choose from. What are the best things can be done? What are the pros and cons of the options? Recommend a line of treatment. You are more than a prescription vending machine. So you are not just a prescription vending machine, right? Always keep this in mind. You are not just a vending machine, prescription vending machine. You are much more than that. So communicate what are the treatment plans. So these are the options that could be. Maybe you can have you can take up a chemotherapy or whatever that is. So these are the ways that we can manage here. So these are the treatment methods. These are the pros and cons. We can say all of this, but the decision has to come from the patient. So listen to their beliefs, fear, problem, and constraints. Even if we give them the best suggestion, it's not necessary that they might take it. What if they want to like follow some Ayurvedic treatment? What if they want to go to some tantric and do something? It can be possible. Their belief system is entirely different from what you are going through. So the best part from our end is to communicate what can be done. So these are the treatment options. These are so and so that can be done, and this will obviously taking up the decision is up to the patients. They might take up or they may not take up. Okay, but from your part, you might have to convey everything. Participated decision by consensus. For example, the patient, the family, doctor, everybody should be like coming to a concluding point. Summarize the interview. Like so and so happened. So and treatment has been decided on. So this is how we'll be like taking it forward. Confirm the treatment plan, including the next visit. Before you close the interview, ask, is there anything else you want to ask? See, this is always going to be the patient is always going to remember this. You at least ask if at all there is anything. Maybe the patient might have certain concerns, sometimes fears. Okay, what if I take this treatment and something happens? What are the side effects? The patient might have their own queries and doubts, and also this question might give a doorway to that. Is there anything else you want to ask or say? Close the interview, leaving the door open. In case you need, contact me or my team. You can call at the given number. So never share your personal number or anything. You can say, I'll be available from this time to this time, or the team members will be available from this time to this time. So this is the contact number. Again, greeting, make eye contact, no, say bye, goodbye, good day, namaste, or like apasheri. That we use in Malayalam, right? So that's how we bring our history taking to conclusion. Okay, I hope that is clear. If at all there is any queries, just put up in the chat box. Right. So what are some of the take home messages? Empathy as an experience depends on how we behave with our patient and their families. And we never sympathize, we have empathy. We need empathize. Patients and families remember how they were made to feel, how they felt. Okay, they never say what you said, they never remember what medicine maybe you might have said or whatever other things that you said, but they always remember how you made them feel when they first visited you. This is always going to be there in their mind. That's mostly what they remember. Talk less, we have 1 month, and listen more, we have 2 years. Practice positive body language and remember the verbal do's and don'ts. Right? So with that, yeah. With that, we come to the closure of that session, communication, basics of communication, okay? So any doubts or queries in the session?
I would like to ask
Yeah, sure.
regarding discussion or treatment options. It is mentioned, do not give menu of options to choose from.
Yeah, right.
Do not give or to give.
We cannot give a menu of options. Maybe we can give 2 best options that can be done. We cannot give a menu of options. Like we cannot confuse the patient who's sitting in front of you. For example, where was it? Like we cannot give a lot of options. Maybe there are like maybe 5 6 options might be there. It depends upon case to case, right? So we cannot give a we cannot give them with 5 or 6 options. Maybe we can take up the best 2 options that can be best for the patient, best for the patient's quality of life or quality of treatment, and maybe the patient can choose from that. That's what is meant by do not give a menu of options. Menu means we cannot give 10 options to them, which will completely confuse the patient. The patient itself will start thinking, okay, there is like 10 options in front of me. I myself don't know which is like best for me or which I have to like choose with the 10. Maybe the patient will go for another review or might go to another doctor for review, so that, to take a 3 or 4 opinions, the patient might have to run here and back. So we can provide them with 2 or 3, like maybe the 2 options that is best fit for the patient according to his or her case, and maybe the patient can choose from that. Again, it is not necessary that the patient will choose. Maybe the patient will go and maybe follow homeopathy or Ayurvedic treatment, or maybe do some puja or tantric puja or something like that, so that, or maybe hold a prayer in the house. We have seen that. We have seen, maybe we'll say the treatment options, and even then they won't comply, and they will be doing some prayers. Maybe we have seen cases like that. Did I make that clear? Yes.
Thank you so much. It really makes sense, because that might overwhelm the patient, isn't it?
Exactly. Right. Any other queries? Anything else? Thank you so much. To hear your pronunciation of your name.
Yes, it's Gretchen. Thank you.
Gretchen. Thank you. Okay, fine. Right. So if there is no doubts, we'll move on to our case presentations, since we have one, I think. Right. I think it's Nancy, right? Nancy's. Nancy, are you audible?
Yes, ma'am.
Okay, thank you so much. So shall we start? Are you ready?
Can you see me, ma'am?
Yes, 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 Nancy.
Yeah. Good afternoon, ma'am. My name is Nancy Fernandez. I am a staff nurse on PSC Sangye. My patient is a male
Patient is diagnosed with acute pancreatitis with alcoholic consumption with insomnia. The complaints: patient has nausea, vomiting, severe epigastric pain. Patient is worried and cannot communicate properly. Difficulty in sleeping, distension of abdomen is there, and slight pain after he is having after. History of the patient: 50 years old male with acute pancreatitis with epigastric pain for since 4. History of alcohol consumption: patient is restless and uncomfortable. This sclera of both the eyes are ectric. On examination, patient appears very ill, restless, uncomfortable. There is a tenderness in the epigastric lesion. Tachypnea is present. History: heart rate is 98 per minute and blood pressure is 138 by 90 mm of Hg. Treatment and investigation. Treatment: IV fluids, fluid therapy is given, such as ringer lactate and normal saline is started. Patient is kept nil by mouth. Pain controlled by medication. Nutrition support is given. Antibiotic therapy is started. Significant investigation: complete blood count and serum amylase, serum lipase, and liver function test is done. Abdominal ultrasound or CT scan of the abdomen is done. Psychosocial aspect: he is married and has 2 children. His wife is a housewife and he is a primary caregiver. He has Paka house. Patient appears sad and depressed. He is unable to speak because of his having pain, severe pain. Cannot communicate. He communicates with writing and sign language. Medication such as diclofenac status is given. There's a tramadol BD with 100 ml NH started. Fortrin was given SOS. Antibiotics such as amoxicillin 625 mg BD was started. And for injection one day is given BD, and diazepam 10 mg HS was given. Main concern: uncontrolled pain, insomnia, anxiety. Patient is worried, cannot communicate properly. Summary: 50 years old male with acute pancreatitis with acute epigastric pain with significant uncontrolled pain and restless. Discussion point: anxiety, pain, insomnia, restlessness. Thank you, ma'am.
Thank you, Nancy. So, okay, let's forget about the discussion points. Okay, what will be the first thing that we'll be doing to this patient? This question is open to all. Okay, not just Nancy. So, what will be the first thing that we might be doing with this patient? Exactly. Thank you so much. So the patient is in unbearable pain. Okay. So that will be the first thing that will be taken care of, no matter what obviously the other things will be taken care of. But see, we need to find out the ways in which the pain can be reduced. I know that already some medications are being given, but even then the medication is not proving or is not being effective. So after providing other pain medication, if the pain has not reduced, then maybe we'll be assessing for anxiety or any other psychosocial issues that the patient might be going through, right? Then we'll be assessing for anxiety, we'll be assessing for depression. So obviously the patient, I think, was mentioned as alcoholic, right? Was alcoholic, right? So that might be some kind of drug-induced symptoms. Psychological issues might also be there. Psychiatric issues might also be there. See, we need people with expertise on those areas to identify that. So we need psychologists or psychiatrists to identify regarding the anxiety, to what level it is having, regarding depression, if the patient is going to having any depression or anything like that. And for insomnia, is it any organic condition that is causing him insomnia, or is it the psychological concerns that is posing him or is causing the sleep disturbances, right? So when it comes to insomnia, we need to find the cause of it, where what is the cause, and obviously we need to start medication for that also, right? And again restlessness also will follow that. So first and foremost thing will be the pain management, right? So at that, the expertise, whoever is expertise in those areas of anxiety, insomnia, they might have to do a assessment and do the follow-up sessions. If medication is required, maybe we need to have psychiatrists. So that is how the whole team is going to work, right? But when it comes to communication, what do you think might be needed here with regard to our topic today? Okay, we need to have an idea of whether the patient is aware of his diagnosis, of his prognosis, etc. Right? And then we need to have an idea whether the family members, that is the wife and kids, is aware of the diagnosis and Nancy, right. Are you trying to converse with us? I guess that would have been a mistake. Okay, right. So we need to have an idea. We need to properly communicate with the patient and with the family members of what the diagnosis is, what the prognosis is, how we are going to manage, what are the treatment methods that we are going to do. This has to be clearly communicated with the family members. If the patient is not oriented or is not in a state to comprehend the information, then we need to sit with the caregivers, that is the wife or the kids or whoever is standing with him or is doing the caregiving part. We need to have a communication with them and have a very clear idea. Okay, this patient is having so we are giving this. Most of them, they may not have any idea. Okay, what the patient is going to. Okay, we are just giving some medicines and we are just doing some random treatments and then we are leaving. So they may not have a proper idea of what is happening. So make sure that you, the team members, that is the expertise, the other expertise, psychologists, doctors, physicians, nurses, everybody is on the same page. Along with that, the caregivers, the patient, everybody is in the same page. Make sure that everybody knows about the patient's condition. Everybody has communicated properly regarding the patient's condition, the treatment plan. Everybody is on the same page. Make sure that everybody is on the same page. That is very important. Not just with insomnia, main cause is anxiety. It's not for insomnia. The cause could be any. It could be of multiple concerns. Okay, it differs from patient to patient. It can differ from person to person. In fact, so it could be linked, but we are never sure unless we have a very proper communication with the patient. We need to know why the patient is having or why the patient is having insomnia. Is it anxiety related? Is he like having any concerns regarding the future? Maybe the concern regarding his children, concerns regarding any other financial concerns. So we need to find out all these things. So this a physician or a nurse alone won't be able to do. So we need all the team members on the place to find out the exact, have a very proper communication with the caregiver to know the complete history of the patient or complete. And we need, as I said, I think it was mentioned in the slide that the patient is not able to communicate and is using sign language and written language, right? So we need to find out ways ways in which we can get information from the patients to know what the reasons of insomnia is. It could be anxiety, it could be disease related, it could be psychosocial, it could be financial concerns, it could be the anxiety when it comes to the children or his future. Maybe it could be just a thought that maybe if I sleep I will die. It has happened. Maybe the fact that he's afraid of his disease condition. As I said, it could be anxiety related, or there might be a multitude of reasons might be there for insomnia. All right. So immediately we need to assess. First and foremost thing will be like doing the pain management, and then we might need to know where the patient's comprehension is about his condition, where the caregiver's comprehension is when it comes to the patient, whether they have an idea of the patient's conditions, the prognosis, the diagnosis, the treatment plan, what we are trying to do here, whether they know what all the things that we are doing. So we need to identify that, and then we need to assess. Then comes the anxiety, the depression part, the insomnia part, the restlessness part. We need to find reasons for this, if at all there is, right? Any other queries related to the case presentation, case discussion? It could be case or anything else regarding the topic. right? So we'll wind up. So we'll be taking this communication part a little more forward with breaking the bad news and collusion in the next session, I think, right? So thank you so much. Thank you so much, Nancy, for the case presentation, and thank you
Thank you,
all.
ma'am.
Thank you.
So, thank you, Rajika. I know that you were having a very busy day and still you found out time in between that schedule to join us and interact with us. And thank you all the participants for making the session interactive. At least some of you are actively listening. It was very evident from your responses in the chat as well. Thank you so much for that. And Rajika will be joining us in the next session as well and communication part 2. So till that time, this is Sripriya along with Ms. Rajika signing off from the Tips Eco Hub. Take care, everyone. Keep spreading happiness. Bye bye.
Thank you.